Okay, so hi everybody. This is Lucia Knight. Welcome to the Division of Social and Behavioral Sciences new meeting. We're pleased to have you here, and hopefully a couple of other people will join us online as we get started. I am pleased to present Professor Enid Schatz, who's joining us from the University of Missouri, Columbia. Enid is the previous chair of public health at the University of Missouri, and is now Assistant Dean of Graduate Studies at the university. And Enid is going to present about some work that she and I have been doing for the last few years around aging and the older people living with HIV. And she'll take us through the presentation, and then we'll have some discussion and questions afterwards.
Thank you very much. All right, well, thank you, everyone. Thanks for having me. Thank you to all the people in the room.
If you're here, you can come and join us in HEU.
This presentation is on a paper that Lucia and I wrote. The title of the paper is Social Support for Improved ART Adherence and Retention and Care Among Older People Living with HIV in Urban South Africa. A complex balance between disclosure and stigma. So this work, yeah, two computers. So I guess I so this the background for this paper comes from it was motivated by the fact that there are increasing numbers of older people living with HIV. Some of these are people who were on antiretrovirals already and have aged into this age group, but there are many who are testing for the first time in their 50s and older, and needing to get onto the older. So the population living with HIV is aging, and they're the population of older people who are living with HIV have unique vulnerabilities because of the intersection of age and HIV stigma. Also, they have a unique set of comorbidities that we don't see as often in younger age groups. So non-communicable diseases, in particular, other things around frailty of aging, etc. Okay. So this can see that.
Sorry, we just realized that you were seeing the presenter view. But let's carry on and I'll get Okay.
Now I can do it. Yes. Okay, perfect. And also as older people who are transitioning out of work and have life course changes, they also oftentimes lack social. As we know from younger populations, social support in lower and middle income countries often is improved. Social support improves ART adherence and retention and care for younger populations. So one of the things we wanted to look at was, is this true also for older populations? And then finally, HIV status disclosure often plays an important role in mediating social support and may reduce stigma to facilitate social support, and that's been found in other populations as well, but we don't know if that's true for older people. All right, so some of the gaps in the literature that were there before we started doing this work included that there was really not a lot of information on the role that and relationship between social support and aging or living well with HIV for this age group. So we wanted to look at, can social support improve ART adherence and retention and care for older populations in the way that it does for younger populations, and also that older persons often experience this increased dependence on their social network as a result of aging, but we're missing this documentation of the complex associations between disclosure, social support, and HIV stigma for this. So this work draws on qualitative research with older people living with HIV to document two key things. One, social support amongst older people living with HIV in urban South Africa, and the ways that disclosure mediates social support and moderates stigma. So those are the kind of key aspects of what we're looking at in this particular project. So the data come from a study that Lucia and I were working on actually when I was at UWC with her in 2017 as part of a Fulbright, and we were collecting qualitative interviews with older people living with HIV. The focus of the study was on social support and health, and so we did qualitative interviews in Manga and Khayelitsha. We purposefully selected the respondents and who were over the age of 50 and had tested positive for HIV. We used a local NCD research project survey list as one starting place, as well as that had a self-report HIV status question, as well as convenience sampling at clinics. As this audience well knows, these areas have populations that are predominantly Black or have low socioeconomic status and high rates of unemployment. The two areas, Manga and Khayelitsha, have varied infrastructure, but generally poor infrastructure and have a mix of formal and informal housing settlements. But they both have relatively good access to healthcare services, social and developmental, non-governmental organizations, et cetera, community initiatives and social development in the area. So we knew that there were people who were attentive to the needs of older persons, but not necessarily older persons who were living with it. So we talked to 23 respondents, 14 of whom were from Khayelitsha, the rest from Manga, 10 of whom were women. We miraculously found 13 older men, although you'll see that they're more in the younger, older age groups than older ones, and there were differences between men and women in terms of responses. About half of them were between 50 and 60, and about half were older than that. We also did 10 key informant interviews with people who were working in the community and had engagement with this population. So that included 5 primary healthcare staff, 1 home-based care, 2 social workers, 1 senior club employee, and 1 staff employee. And this particular paper doesn't make use of those in terms of the data that show up in the paper, but they do inform what we understood about the resources and support that older people had in the and we conducted a thematic analysis for these. So the key findings, I'm going to kind of go right to the meat, and then I'll give you some of the evidence that allowed us to come to these conclusions, are that older people living with HIV receive most of their support from their family, and the support can facilitate adherence to ART and retention and care. So this is kind of showing that the same thing that has been found in younger populations is true for older populations. But social support from wider networks is more complicated, and I'll talk about the ways that people interacted with the community and how involuntary disclosure was often the main way that people's HIV status rather than formal disclosure. Or inadvertent disclosure was what allowed people to for other people to know about their HIV status. Social support is facilitated by participants' disclosure, making disclosure a mediator of support, and this was particularly true within families that once they told family members that they were HIV positive, family members could help them in some way. Perceived stigma at times limited disclosure, making social support less accessible when stigma was high. And that gender, age, and pre-existing vulnerability affected disclosure to and support from. I think hopefully you'll see these themes and threads come through in the findings of my So the first set of quotes here highlight our first theme, which was that families accept because no one asks to be sick. So in these quotes, you'll see that when individuals disclose to family members their HIV status, that the response was generally, even if it was surprise at first, the response was generally positive because people support each other. So the first woman says, I found it difficult when I found out that I was HIV positive because in my family, my status is known by my sister only, the one who comes after me, but by telling her, but by me telling her. It wasn't easy because I was shocked, plus it was known by my wife and my children. In the family, what made you choose your sister? Why did you tell her? My sister and I support each other. So this is an older man whose wife was also HIV positive, so they view each other. The second quote is from an older woman who was a widow. This was one of the main differences between the men and women in our sample. Most of the men were married and many of them, their wives were also HIV positive, whereas most of the women in our sample, and the wives were often younger, so below the age of 50. And most of the women in our sample were widows. So she says, if HIV status is only known here at home, the nurses say that my family must know because I might become sick. They must know what is what. So this woman is saying that she's been encouraged by the staff at the clinic to share her status with her family because it's important if she gets sick for them. And then finally, another woman who was single and 60 said my family felt hurt, but they said that they have to accept my status because if not, that will make me sick. So we must feel free the same way in which you are about it. And I said, my children, you must accept this. I've also accepted it because I did not invite this illness. Nobody asks to get sick. So the idea is that while it may not be something that they feel good about initially in terms of sharing, there was this acceptance among family members once the information was shared. When we looked at how people disclosed within the community, it became more complicated. In many cases, when there was disclosure beyond the family, it was unintentional. So whether it was like in the first case, there's a woman whose neighbor happened to work at the clinic, so the neighbor saw her going to collect her medicines. That was the way that she her status became known. Only a few respondents said disclosure to those in the community was more actively chosen. But even this person was there was kind of those who it was chosen and some for whom it wasn't. So some just hear about my HIV status when I chat, and the advice I give them is they must be careful of it, and I try and give them that counseling that was given to me. So this person feels it's important for them to know and to share their status within the community so that they can give advice to others about how to manage being HIV positive, and that it's something that you that it's okay to be in and you shouldn't feel badly about. But there were men in particular who feared stigma related to sharing their status, and they were particularly worried about sharing it beyond their families. So if they were still working, this was an issue. So one man said, no, at work I never told them. If I were to tell them, I could lose my job, or they would talk about it, and yet that's not right. It's yours and your family's. It's my problem, it's not theirs, and I don't ask them with regard to themselves. Sometimes at other places, they would want the doctor to write down what you are suffering from. I've never said the doctor must write. I just told them I've got TB. Even in the church, I never tell them. I have a reason. This is my secret because they also have their own illnesses, which I don't know about, and it's my secret and my family's. It's yours and theirs only. I don't see the need for anybody else to know, even if it's a friend. I don't trust a friend anyway. He might talk about it to other people. So some of it is just about sort of privacy, like we don't necessarily have to share all of our information with people in the community, but some of it is also about worry about HIV in particular. So he's willing to share that he has TB, and we'll see in some other cases that older people felt comfortable with people knowing that they had health issues, but maybe not HIV. So they could kind of use the fact that they were older and they had these other health issues to almost mask their need for HIV care. People wouldn't question that they were going to the clinic for something. They just didn't have to articulate what it was exactly. Another older woman said, there's no one else that I can say I'm looking to for support. People in this community, we just talk, but not in a way that they can perhaps help you with something. I would describe myself as not being alone because there are people that I stay with here in the community. There is nothing that they can help me with, though they are here. So even though she felt like she was part of a larger entity, she didn't feel like she could really ask for help from this broader community. And yet we found that having social support was linked to better adherence. And so, kind of coming out of this, Lucia and I are thinking about ways that we can build interventions that might support this social support aspect. In a lot of the literature that's out there, there's sort of a separation between emotional, instrumental, and informational social support. It was hard to disentangle these in our data. I mean, in part because we didn't ask people, like what kinds of emotional support do you give? What kinds of, it wasn't a survey with a list of types of support. We were asking more generally about support, but the kinds of examples that they gave, we saw as really sort of straddling some of these lines. So people talked a lot about family members reminding them to take art, and really this felt like it was both instrumental in that they were providing practical support. They were giving a reminder that it's time to take their medicine. But it's also really emotional support because it was an exhibition of love and caring. It was a way of showing that I care about you, that I want to make sure that you're taking your medicine on and staying well. So disclosure allowed extended families to become a key source of support in ways that directly and indirectly impacted art adherence and retention care. And so one of these was these sort of reminders. Another was taking people to the, helping them, facilitating them getting to the clinic when they have to go to pick up their medicine. Others were around helping them get food. There's a lot of information in our, despite the fact that there's not really instructions at this point in time that you have to have a certain diet to take with your art. There was a lot of beliefs within the community that you have to have a particular nutritious diet in order to be taking your art. And so there were people who said things like, oh, well, my son, buys special food for me or makes meals regularly so that I have the right food to take with my so now I'll show you some of the quotes that highlight. So this blending of emotional and instrumental support came through in a number of different ways. So this person said, I'm happy here because the people living in my community are warm people. We help each other. Even when I started becoming ill, they used to be very helpful. They brought me food and things that I needed. So here's that instrumental type of support, but also that feeling of these people care about me. And so it's also good. An older man said, even my grandchild, he would ask, Father, have you already taken your pills? Sometimes that meant that they knew that they were HIV positive. Sometimes it just meant that they knew that they had to take medicine. So it wasn't necessarily they knew what the pills were for. And also, Mother, have you already taken your pills? Because he's married to someone who's also living with HIV. When I say he should give me my pills, and then he'll ask, should I also give to Mother? So there's this caring aspect of taking care of them as they. Another older woman said, when I'm very ill, my children come and fetch my medication package on my behalf. So this was something that came out of it that we've written about separately, is that it was important that people could send others to get their medication when necessary, whether it's because she was very ill related to symptoms related to HIV or something else. So a lot of the older people had mobility issues that were just due to age. And then the final one is, yes, even when I have to go to Tigerberg, one of my sons, because two of them have cars, will transport me and will phone me while there to find out how far I am and if I have attended to, and then when I'm finished, will fetch me again. So this was this sort of instrumental support that allowed people to take their medication on time and to with food and to get to their appointments, but also kind of showed that the family was willing to step up for them. But there were people in our sample who were missing support, and it was clear that they didn't have either the family members here in Cape Town, in Uganda and Kailicha, or they didn't have the kinds of relationship with their family that would allow for that type of support. So one single older woman said her daughter was here in Cape Town, and the interviewer said she not have a contribution, and the older woman said, no, when we pass each other on the road, then sometimes I feel as if I can kill myself. We don't even greet each other. I don't know what I've done to her. I've been asking her all these years. I don't know what caused the rift. She doesn't explain. So this wasn't necessarily anything having to do with HIV, that they were estranged, but the estrangement meant that she didn't have someone to go to for assistance around support. Another older woman said, in a different situation, said that they know about her HIV status, especially her daughter. It could be that her son doesn't know because he doesn't care about anything, but the other children know about it. So there were some cases where there was sort of this mix of getting help and not getting help from various family members. While this lack of support wasn't necessarily driven by HIV stigma, it was clearly distressing to participants that there were people with, especially children, on whom they couldn't rely. So where do our findings fit compared to the existing research? So as I said at the beginning, the social support from non-family members. So in high-income countries, a lot of the data around social support being important for retention and care and ART use is really about non-family members contributing to the well-being and support of people living with HIV. And we found that those kinds of networks are not as crucial for older people living with HIV in Manga and Kailicha, but it's families who are really the key individuals. This may be in part because in a lot of high-income countries where this research has been done, the individuals for whom they're asking about are often older gay men who maybe have a partner, but otherwise are less likely to have kind of the family structures that we see the older people in our study having. So in those places where maybe family is more your chosen family rather than your biological family, those like wider networks of friends and community seem more important, whereas here where people are really reliant socially on family as they get older anyway, it makes sense that that family is there's existing evidence that family disclosure can lead to more support. We've mainly found this, but it can also attract negative social outcomes. And that's what's been found elsewhere. There were some worries about this, but it was more about those negative outcomes from the community and from family. Sometimes fearing stigma related to HIV as a result of age was a driving factor in the disclosure and in seeking support from family and community. And that's similar to what we found in other work on older people living with HIV in other places in South Africa and other places in sub-Saharan Africa. This stigma and fear of it often we've seen in other places comes from like health providers that older people are reluctant to share their symptoms or ask for testing because older people are assumed not to be sexually active, and so the providers shame them, or they assume that the providers will shame them, and so they don't disclose their need for care. But despite these fears or concerns about disclosure to family, most of the people who did choose to disclose to their family members were met with relatively positive responses. So some were surprised that they were that their family member was HIV positive, and others were. But the like response was more as we might expect of people who had close relationships, that they were open to providing care once they need. So one of the pieces of this research that is leading to the sort of next steps is that because of what we found in terms of the way that that family relationships work, that there's evidence that there's this constant negotiation based on the complex interplay of obligation to family, affective ties or love, and reciprocity, that when families have more HIV competency, that there's less contentiousness in dealing with HIV in a family. So we show where relationships were already strained or there was existing conflict, it was harder to rely on family members for care and support. And so one of the things that we're looking toward is how do you help both repair those relationships, but also make sure that family members have information about HIV and ways to be helpful to their families when such things happen. I touched on this at some point earlier, but age, because of aging, there was sometimes this assumption that there was a lack of a need to disclose. So it wasn't so much about whether someone felt they wanted people to know that they had HIV or not, or that they needed to say that they were living with HIV in order to access some sort of assistance or care, but instead that older people could kind of rely on the fact that they were old and needed help and may have other comorbidities or disabilities to use as a way to get help without needing to share that they their HIV status. So for younger people, when they get ill or have a sudden weight loss or gain or need healthcare access or need to take medicine every day, they have to have a justification for that. So that's often why younger people need to disclose to someone, because it seems strange that someone who's younger is accessing care regularly or taking pills every day. But for older people, they often have an assortment of pills that they're taking every day. If I think of my own parents, and they're like little pill box that is full of things for each day. And so it doesn't seem so strange when they say, like, can you help me get to the clinic? Or I have these pills that I need to take today. So some of the grandchildren who are reminding them to take pills don't know which ones are for diabetes or hypertension or something else, and just say, you should take your pills because that's so. This need to explain was less true for older. So the high rates of both TB and NCDs mean that in many cases, older people were able to rely on support, often relatively small scale and related to their emergencies, from people within the community without a need to disclose. So they could get the help they need from the community, but without having to say it's because I'm living with HIV. And so these good relationships that I talked about within the community and getting assistance for being older and unwell were less related to them saying to everyone, I'm living with HIV and this is why I need help. Which, maybe has something to do with the stigma of HIV, but maybe is also just about people not needing to share all of the specifics of their health concerns with a wider community. So in terms of next steps and how we're planning to address some of these findings, given that social support, particularly from family members, amplifies HIV care access and adherence, encouraging disclosure in some way may stimulate household HIV competency and is likely to address both the anticipated stigma that some of the older people felt and support improvements in older people living with HIV health outcomes. We're thinking about public health interventions that could be designed to improve households or families' HIV competence and encourage disclosure, which, as our results show, is a key first step for older people living with HIV to be able to access social support within their families. This isn't necessarily within the broader community. This may be particularly important in terms of increasing competence around providing informational support. So we found that there wasn't a lot of informational support, and the sort of information that people had wasn't necessarily correct. So the sort of information about having to take your medicine with particular food or have a particular diet was sort of the only information that seemed available to these families. But also in combination with other medications, given the high level of multimorbidity. So it may be important that family members have more knowledge of what all of the illnesses are and all of the things that older people may need assistance with and attention to. It may be more important to know about diet if your older relative has diabetes or hypertension, and that may be why they need to have a particular diet, but it may not be for their and so this kind of informational support was not reported in the same extent as emotional and instrumental support. And so thinking about what are the pathways that we might get this information to family members through, and what is the important information for them to know in a holistic sense for older person's health. So right now, Lucia and I have a small grant from the Brown CFAR that is allowing us to do some formative research that we proposed at the end of this paper around thinking about developing components of an intervention that would support an environment where older people living with HIV can gain, share, and translate HIV-related knowledge to enhance prevention and treatment behavior, to feel safer about disclosing their HIV status, and dialogue about HIV, to take some ownership of their HIV condition and responsibility for safe sexual practices, testing, and art. Since we know that older people do not necessarily stop having sex just because they're over the age of 50. To feel supported, to adhere to art and remain in care, as well as to manage medication and care for their comorbidities, and to be receptive to outside support. So in this formative qualitative work, we're planning to look more closely at stigma, how it's experienced by older persons, because it came up in this original study, but we weren't focused. That wasn't one of the aims of the study. And to think more directly about how stigmas born out of age, health, gender, HIV intersect in ways that are unique for this population. And then finally, building on this idea of HIV competent families that comes out of the SPH work that Lucia leads. I think that's my last slide. So that's all I have.
Great.
Questions?
Thanks, Enid. We can open the floor to questions. We can start here in the room and then move to the people online. If you have a question online, you can raise your hand in the meantime.
Comments, not questions. But what struck me with the trajectory of caregiving is the sort of intergenerational shift that it's now, children and grandchildren caring for their parents, who should be, usually the other way around. And then in that sort of a context, there's something almost that sounded either almost functional or transactional in terms of telling is contingent on whether I anticipate I'll receive support. So if I don't think I'll receive support, then I won't tell you. So there's some sort of, transactional or functional type of disclosure, something that impacts disclosure, which I found quite interesting. The other thing is I also wondered about, the talk of comorbidities for aging people, and my interest is in cancer research, and how cancers that affect older people that may affect their sexuality, there may be stigma around, like I'm thinking of cervical cancer and prostate cancer, and how maybe reticence to disclose even symptoms may, because of fear of being stigmatized, because like cervical cancer, like what are you doing to get it, and but there may be some sort of similarities. So it might be interesting to see how those other comorbidities, when you're looking at stigma, how they play out in terms of disclosure and support, because there are some that may have more stigma, and in some conditions may have more stigma. People do not have a problem saying I'm diabetic, but that I have prostate cancer, cervical cancer might be different.
Well, and some of the symptoms that would get you a diagnosis are also things that maybe you feel ashamed to disclose because you think that it's from an STI instead
or that are HIV related,
the
cervical cancer. So that I suppose that would be an interesting thing to see what comes out of that. So that when you're talking about holistic support, then there are, other honesticities, other conditions that fit in and that relate to that HIV that can be propagated by HIV or that can lead to HIV and stuff like that. So thank you for sharing that.
I think that just to go back to your first comment, I like that idea of like functional disclosure or like transactional disclosure, because I think that's one of the reasons why people didn't feel like it was useful in the community setting to disclose, was that there wasn't that same function. Like it wouldn't get you more support necessarily, whereas at home maybe it would, like if you assessed that if you told your family, they might be surprised, but then they would be willing to help you.
Take your chances.
That you're going to take your chances, but in the community, it's a more haphazard or like less the like positive end result is less clear, and so the reasons for disclosing become
Thanks very much. Very interesting. Just to follow up from it, it struck me that if you talk to health workers, as far as health workers kind of generally, it's reinterpreted as a chronic disease. That for the people who have HIV, it's not reinterpreted as a chronic disease. It's still an exceptional disease. So I wonder if that's something that came out in your thing, because they would have been taking all these branch of other tablets. But HIV treatment was different.
It's interesting. I feel like not in this work necessarily, although maybe there was also some work, but I've worked in other parts of South Africa and in Uganda, and in some ways people feel that HIV is less problematic than some other entities, because once you're taking ARTs and are adherent to them, that you more or less cured your HIV. You just have to do it forever. So in that way, they do see it as chronic, but they see the hypertension as something that is uncontrollable, or their diabetes is uncontrollable, and they don't have quite as much power to control the outcomes of that. So I mean, it's almost the reverse, that once they're controlling HIV, it seems like they feel less like it. They feel it's more manageable, and it's really like when we ask them, like, what are the hardest things for you, they say things that not having to do with HIV and not having to do with their communicated.
And our experience of healthcare workers was slightly different. So although we didn't speak to a lot of healthcare workers, we did speak to some that wasn't reported here. And the testing experiences of the older people were quite different to the testing experiences of younger people, especially those that weren't in relationships and weren't linked to their partners. So men had and we've written a paper about it, but men had a very different experience, because they tended to have younger partners who were tested as part of ANC and then were linked in through that route. But women often experienced symptoms and had issues for a long time and weren't often testing until all of their other conditions were diagnosed and treated, and they were still having symptoms and issues. And so although they may be treated as chronic, they weren't necessarily considered at risk, if that makes sense. So they weren't. So I think, and that came up in other work that Enid's done before, around this idea of older people not being at risk because they don't have sex, and they aren't kind of part of this population. And I do think in this instance it was the woman mostly, and those that were slightly older and were kind of testing in later life, which kind of makes sense, but it is also a concern where point-of-care testing should be offered to everyone.
Yeah, I think in terms of testing, that the health system is set up to really test in that reproductive age, and then the men who are linked to those women of reproductive age. A lot of the work that we've done shows that's not necessarily the best way forward, since as people age with HIV and things change, missing something.
Can I ask another question? So I know that the age group is relatively young. But did you ever come across students older?
I don't think we had any in this data. In the rural area where I've worked, there were definite and more not physical abuse necessarily, but more abandonment. So like older women who really don't have anyone who's helping them, and who have children who have moved to the city, who don't come home very often, and that sort of thing. But not so much. I mean, we weren't asking questions about that. Although, a lot of the interviews are pretty open, so if someone wanted to share that, there was space.
And perceived neglect.
Oh yeah. But yeah, I think more neglect rather than.
The usual problem with older abuse is younger family members exploiting the older person for their attention.
Yeah.
And there were some instances where there were clearly quite complex relationships within families and households. So not just those that had moved out and
kind of ignored them, but within the household. And there were a few that forwarded on some of those issues, but the individuals themselves seemed quite strong for it was.
Are there any questions online? Please unmute yourself or raise your hand. Questions? Do you have any questions? Thanks, Enid.
Yeah, thank you
Very much.
much.
We'll report back when we have results from next stage of our work.
I'll come next year.
Yes.
Next time.
But thank you for joining us. Thanks for joining us online, everybody. Thanks for